In this video, we'll be talking about a key measurement in determining how effectively someone's heart is working: cardiac outputs. In a healthy individual, cardiac output can vary widely depending on the body's needs. Resting cardiac output is somewhere around 5 to 7 liters per minute, but it can rise as high as 30 liters per minute during strenuous exercise, and even more for very highly trained athletes. Cardiac output is defined as the volume of blood pumped out by the left ventricle in 1 minute. That's why it's reported in units as liters, a unit of volume, per minute. Cardiac output is a function of heart rate and stroke volume. So if you take the number of strokes per minute, it's the heart rate, and the volume of blood that's ejected in each stroke, the stroke volume, multiply those two together, and you get cardiac output. What this means is that anything that affects either heart rate or stroke volume is going to affect cardiac output. I mentioned your cardiac output goes up when you exercise. Exercise affects both of these. It increases the heart rate and it increases the stroke volume. The medulla oblongata in the brain contains key centers for regulating cardiac output. So why is cardiac output important? Well, obviously getting blood out to your tissues is vital. If cardiac output is too low to meet the demands of the body, you can develop what's called congestive heart failure. And this can happen from a number of different causes. If you have clogged coronary arteries and you don't have enough blood getting to your cardiac myocardium, this can lead to congestive heart failure. Atherosclerosis is the term for the arterial disease that can block blood flow. Chronic hypertension, that's chronic high blood pressure, can weaken the heart over time. It increases the amount of pressure the ventricles need to exert in order to eject blood into the aorta or pulmonary trunk. And the harder the ventricles need to work for each ejection, the weaker they get over time. Myocardial infarctions, heart attacks, can also lead to scarring of the cardiac muscle, which decreases the heart's ability to pump blood, because scar tissue is not as functional. It's not functional at all. It does not contract the way cardiac muscle should and needs to. The reason why it's called congestive heart failure is because you see fluid accumulating in areas where it's not supposed to, when the heart is not pumping an adequate amount of blood. If you have congestive heart failure of the left ventricle, you get fluid building up in the lungs. If you think about circulation through the heart, if blood isn't getting pushed out of the left ventricle, then there's no room for blood to drain into the left atrium, and so that blood and fluid from that blood pools up in the lungs. You get pulmonary congestion, called pulmonary edema. This is what pulmonary edema looks like on an x-ray. This is a person with pulmonary congestion. This dark space is the air in the lungs. You should see the lungs reaching down into the chest to about there, but approximately the bottom 2/3 of the lungs are filled with fluid, and that's why they look white in the x-ray instead of this nice, healthy black. If you have failure of the right side of the heart, fluid builds up in the periphery. So you will get lots of fluid accumulation in the abdomen. It's called ascites, fluid accumulation in the abdomen. You'll also see swelling in the ankles and legs as the fluid that's pooling up in the tissues is drawn down by gravity. You can also have symptoms, coughing from if you have pulmonary congestion. Coughing is particularly, you see that. You can see shortness of breath. And you may just have, a general sense of fatigue because your tissues aren't getting the oxygen that they need. Heart rate depends on the frequency of depolarization in the sinoatrial node. The sinoatrial node exhibits vagal tone, which means that the parasympathetic fibers from the vagus nerve reduce the heart rate. Right? So the resting heart rate is actually below the intrinsic rate of the sinoatrial pacemaker cells. An abnormally low heart rate is called bradycardia. And this can be diagnosed if a heart rate is less than about 60 beats per minute. An abnormally high heart rate is called tachycardia. And this is diagnosed if you have a heart rate over a resting heart rate, I should say. Your heart rate goes up normally when you exercise, but if you have a resting heart rate over about 90 beats per minute, that's tachycardia. But there's individual variation in heart rate, so really it depends on what your normal rate is. Some people might normally have a bit of a low heart rate, and some people might normally have a bit of a high heart rate. There are a number of different factors that affect heart rate. First off, your brain. The medulla oblongata contains little clusters of neurons that affect heart rate, that can either accelerate heart rate or slow it down. You also have parasympathetic stimulation, as I mentioned. The vagus nerve decreases the heart rate. Sympathetic stimulation, which just happens in the fight or flight response, increases the heart rate. There's also a reflex called the atrial reflex. And what happens is that when you have blood returning to the heart, it stretches the atria, and specifically it stretches the right atrium. That's where the sensors of this reflex are located. And that stimulates sympathetic fibers that increase the heart rate. So it's the atrial reflex can stimulate this sympathetic increase in heart rate. You also have hormonal influences on heart rate. So epinephrine from the adrenal medulla raises heart rate. Thyroxine stimulates a sustained increase in heart rate. So that's why one of the symptoms of hyperthyroidism is an elevated heart rate. And conversely, one of the symptoms of hypothyroidism is low heart rate. Several other factors influence an individual's heart rate. Age is one. The heart rate slows a bit with age. Gender is another. There are some heart rate differences in general between women and men, particularly during exercise. Everyone's heart rate goes up when you exercise, but in women it tends to go up just 3 to 5 beats per minute higher. Exercise itself affects heart rate. It increases heart rate while you're exercising, but actually if you're training a lot, if you're doing a lot of cardiovascular work, that can decrease your resting heart rate. So basically a well-conditioned heart has a lower resting heart rate. Body temperature also affects heart rate. As your body temperature goes up, your pulse rate goes up. As your body temperature drops, your heart rate actually goes up at first too, trying to warm the body back up and sending that blood out. But eventually, if you're at a sustained low body temperature, your heart rate will slow down. Ion concentrations in your blood, if they get out of whack, they can also influence your heart rate. Low blood calcium decreases heart rate. High blood calcium, it extends that plateau phase because you have more calcium coming into the contractile cells during that plateau phase, and that just leads to an arrhythmia. It disrupts the heart rate, leads to kind of chaotic contractions. A low potassium level lowers the resting potential, inhibiting depolarization. Just as there are a number of different factors that affect heart rate, there are different factors that affect stroke volume as well. Stroke volume is basically your end diastolic volume minus your end systolic volume. So just to talk a little bit about that, remember the end diastolic volume is the amount of blood that collects in the ventricle during diastole. So at the end of ventricular relaxation, you have a certain amount of blood in your ventricles, and that's your end diastolic volume, right? Then the ventricles start contracting. They start squeezing that blood out. And most of that blood gets ejected, but not quite all. There's a little bit left at the end of ventricular systole. This is your end systolic volume, the amount of blood left in the ventricle after systole. Depends on how strongly the ventricles are contracting, and it depends on the blood pressure in the arteries, which is basically, well, it's called the afterload, and that's the pressure that your ventricles need to overcome in order to eject blood. And the difference between these two is the stroke volume. This is the total amount of blood that was ejected by the ventricle. It's basically the amount of blood the ventricle started with versus the amount of blood that's left. The difference is the stroke volume. That's the graphical illustration of this equation. There are three main factors that affect stroke volume, and a lot of the other factors that affect stroke volume, basically, they act on one of these three factors and affect stroke volume that way. These three factors are called preload, contractility, and afterload. We'll talk about these one at a time. There's a law in physiology, it's called the Frank-Starling law, or Frank-Starling rule, and that rule states, preload is the critical factor controlling stroke volume. Preload is basically the amount by which cardiac muscle cells are stretched before they contract. Now, to understand the significance of this, I need to take you back to the length-tension relationship of muscle fibers. So remember that cardiac muscle fibers have this highly organized arrangement of thin and thick filaments into sarcomeres. Sarcomeres have an optimal resting length. This is the length at which the myosin heads on the thick filaments have maximum attachment to thin filaments. You get basically all of the myosin heads attaching to the thin filaments. If you are below this resting length, so if the muscle is a bit contracted, then all the myosin heads can attach, but there's nowhere for the thin filaments to go. They start to interfere with each other, and the sarcomeres can't contract anymore, and so they can't exert much force. We're looking at tension over here on the left. On the other hand, if sarcomeres are excessively stretched, the myosin heads can't grab on. There's not enough overlap between the myosin heads and the thin filaments. So it's best for sarcomeres to be in this optimum resting length window. Now, skeletal muscle, it's nice. When skeletal muscles are resting, they are just about at this resting length, right? So resting length is pretty much right at the optimal length for skeletal muscle. Not true for cardiac muscle. For cardiac muscle, they are actually a little bit below optimum when at rest, right? So resting cardiac cells are a little bit in this arena. So, what happens when you get blood returning to the heart and filling the heart, that stretches the wall of the heart, and it stretches the sarcomeres so that they stretch a little bit up to the optimal length, right? If they're at the optimal length, they can contract with greater force, and so you get more blood ejected from the heart, right? So if you have greater force, you have more ejection, and that's actually going to decrease your end systolic volume, which will increase your stroke volume. Got it? If you look back at our heart, end diastolic volume is end diastolic volume, if you keep that steady, and you increase the force of contraction so that your end systolic volume is lower, your systolic volume, total amount that was ejected, is going to be bigger, going to be higher. Now, the main factor in affecting preload is venous return. That's the amount of blood that is returned to the heart during ventricular diastole. Right? Anything that affects that venous return is going to affect preload and thereby affect stroke volume. For example, if you have blood loss or very rapid heart rate, venous return is going to decrease. If you're exercising, you have more blood moving through the veins and more blood returning to the heart. So it's going to increase your venous return, leading to an increase in stroke volume. Now, the second major factor that affects stroke volume is contractility. Contractility is the contractile strength, so the strength of a contraction achieved at any given muscle length. So if you hold everything else the same, how strongly can that myocardium contract? And contractility primarily has to do with the amount of calcium that rushes into these cells. If you have more calcium coming into the myocytes, you get more cross-bridge binding, you get stronger contractility, and that stronger contractility leads to the decreased ESV, decreased end systolic volume. And as we discussed with preload, decreased ESV leads to an increased stroke volume, which, let's take it one step further, leads to an increased cardiac output. Now, a number of different factors affect calcium entry into the myocytes. Sympathetic stimulation increases calcium entry, so it increases contractility of the heart as well as increasing the heart rate. There are also hormones, glucagon and thyroxine, increase calcium entry. Digitalis is used in heart failure. It's a drug that's given to heart patients, congestive heart failure patients, to raise cardiac output because it increases the contractility of the ventricles. Hypercalcemia, if you have high calcium levels in the blood, that also increases contractility. These are all referred to as positive inotropic agents, agents that increase contractility. There are also negative inotropic agents, which decrease contractility and by blocking calcium entry into the cardiac myocytes. These are sometimes used to treat high blood pressure. If you have a lower contractility, you have a lower cardiac output and a lower blood pressure. Beta blockers are one example. Beta blockers block sympathetic stimulation to the heart. The third major factor that affects stroke volume is afterload. Afterload is the pressure that the ventricles need to overcome in order to eject blood, and it's basically equal to arterial blood pressure. Let me try to illustrate this for you. If you're looking at the heart, you have an artery coming out of the heart, the aorta or the pulmonary trunk. Let's draw in our semilunar valves. So arterial blood pressure is a back pressure. So arterial blood pressure is in the artery pushing back on those semilunar valves because it's the blood that holds the semilunar valves closed. So if you have a higher blood pressure, you have, it's like having someone standing at a door holding it closed. And if you're on the other side, you want to push it open, like you're the ventricles, you have to overcome that afterload pressure, that arterial blood pressure, in order to send blood out into the artery. Increased afterload gives you increased end systolic volume, which gives you a decreased stroke volume. So if you look back at our heart, keep end diastolic volume the same, and then systolic volume before you increase afterload there. If you increase afterload, then not as much blood gets out. So the end systolic volume is actually higher, and the stroke volume is less, right? Increased afterload, you get less blood ejected, you get an increased end systolic volume, and a decreased stroke volume overall. Afterload is normally pretty constant, but if you have chronic high blood pressure, if you have hypertension, afterload is elevated, and the ventricles have to work harder to get that blood pushed out. This is a brief summary chart of factors that affect cardiac output by affecting either heart rate or stroke volume, or in some cases, both. So over here, under factors affecting heart rate, you have the atrial reflex, which stimulates autonomic innervation, and autonomic innervation from other sources can also affect heart rate. Parasympathetic, slowing it down, remember, and sympathetic, increasing heart rate. You also have hormones that can affect heart rate, like epinephrine and thyroxine. Over here in stroke volume, you have venous return. Venous return can be affected by a number of different things, by overall blood volume, changes in peripheral blood vessels, or by skeletal muscle activity. Increased skeletal muscle activity yields increased venous return. And venous return affects stroke volume directly by increasing the preload and affecting the end diastolic volume and the end systolic volume. Preload actually affects both. Venous return also acts on the heart rate by triggering the atrial reflex, which stimulates, remember, sympathetic fibers and speeds up the heart rate. So venous return has an indirect effect on the heart rate, as well as its effect on stroke volume. Autonomic innervation affects stroke volume as well as heart rate. So we're seeing autonomic innervation in both places. Sympathetic nervous system affects contractility, which affects end systolic volume, which affects stroke volume. Afterload affects end systolic volume and stroke volume. And there are also hormones, like I mentioned, glucagon affects contractility of the heart and affects stroke volume that way. After studying this video, you should be able to calculate cardiac output given a heart rate and stroke volume. Basically, make sure you understand that relationship between heart rate, stroke volume, and cardiac output. You should also be able to talk about congestive heart failure, both some of the symptoms and how you get those symptoms. You should also be able to talk about factors that influence both heart rate and or stroke volume. So factors that influence heart rate, factors that influence stroke volume, and factors that influence both. You should also be able to explain the relationship between stroke volume and diastolic volume and systolic volume, that little diagram that I was showing you. And you should be able to distinguish between preload and afterload.